Society of Pune meeting in our current tenure. And at the outset, I would like to thank advantage of having this is we will get speakers from all across the country and abroad, and we have already got more than 100 viewers that is logged in. As we discussed very informally in the beginning, this was the start of PCNL in our nation, also proudly in the city of Pune. And we are very happy to have Professor S.S. Bapat sir in this meeting. And we would have it our views as long as supine PCNL and prone PCNL is concerned. To me, this topic came because of a personal interest. During my residency in 2007, when I entered Dinanath, on the second day of my residency, Dr. Date was doing a supine PCNL on a patient who could not lie down prone. And I had no understanding what was happening. And then I didn't see him do a lot actually for a period of 3 years. And that had triggered my interest. If we can access the kidney in the supine way and the prone way, then what is the correct way of doing? So no better than him, Dr. Date sir, welcome to this program, integral part of USP, and we would definitely like to have your views when you would like to do a supine PCNL and when you would like to do a prone PCNL. This topic actually was chosen because a month ago, Shashikant suddenly posted 3 cases of his supine PCNL experience, and a short debate started in the USP group. So I have invited Shashikant for speaking about how he broke his cold chain and started doing supine PCNL, and how was his experience in the first 3 cases is concerned. While going around with Dr. Kulkarni across various conferences, I just happened to enter an auditorium where a discussion was going on supine PCNL. And I saw my close friend, Dr. Aditya, speak about supine PCNL, and he was showing a video. We welcome Dr. Aditya Sharma from Apollo Hospitals, Lucknow. He has pioneered his technique of SOML, and he has demonstrated it in many workshops. I've had a privilege of attending one such live workshop where he did a nice surgery. I was speaking to him and he said in the last 5 years, practically, he has not done a single prone PCNL. So we would request him and we welcome him to the Urology Society of Pune meeting and take us through step by step his journey in supine PCNL and mastering the art. We also have with us Dr. Karthikeyan. He's also got a lot of experience in doing supine PCNL. And to his credit, he's the current secretary of the youth wing of the Urology Society of India and the editor of the newsletter. He's been awarded as the MS Surgery Gold Medalist, Dr. A. Venugopal Award. And he's also traveled to AUA USI Fellowship in last 2 years. So a very close friend. We have connected each other and we have made a video on how to use Zoom. Karthikeyan, welcome to the Urology Society of Pune meeting. I would like to say that I've created a YouTube channel of the Urology Society of Pune. All the virtual meetings and hopefully even the physical meetings will get recorded. And if any one of us has missed it, you can just type Urology Society of Pune and you would have our YouTube channel there where all the videos and the meetings will go live. So I request, I welcome you all across the country and across the world to the Urology Society Pune meeting. Shashikant, may I just request you to present your experience on starting supine PCNL in your practice?
Please unmute yourself.
Hello.
Yeah, please share your screen, Shashikant.
Yeah, 1 minute, 1 second. Hello, Pankaj.
Yeah.
Is it visible?
What happened?
Is it visible, my slideshow?
No. You have to, I think you have to open the PowerPoint, then press share screen and then try it again. Right now we can't see your slides.
Okay. I open PowerPoint.
Yeah. Then go back to Zoom and click the share screen.
Okay.
So in the bottom side, there is a share screen button.
Yeah.
Yeah, click on that and choose the presentation, then share.
Okay.
Yeah. Yes, sir, your slides are visible. Make a full screen.
Yes. Is it visible now?
Yes, sir, continues.
Good evening, everybody. And thank you, Pankaj, Sandesh, and Nitin sir for giving me the opportunity to share my initial experience of the supine PCNL. As we know, PCNL is well-established procedure for renal calculi more than 1.5 centimeter in size. We all learned doing PCNL in the prone position, so we feel PCNL is easier in the prone position than the supine position. But believe me, it is just like switching driving the manual car to the automatic car. Doing PCNL in supine position is cost effective to the patient, comfortable to the surgeon, anesthetist, operation theatre staff, and to the patient also. Now, in the last lockdown period, webinars, workshops, CME, online journals, and online are live conferences. And most importantly, our own USP group, WhatsApp group, this triggered me to think about the supine PCNL. As we all know, I think in 2.5 months ago, Jaideep Date sir and Dr. Dharaskar started on the USP group. We should think about the supine PCNL. And I started to think about the supine PCNL. Till that time, I was doing PCNL in the prone position for last 9 years. I learned PCNL by the distant learning. I've seen the YouTube video, those are non-edited, particularly Priti Hospital, Dr. Chandramohan video, and I learned from that. Also, there are many urology groups on the Facebook. They educate urologists, and of course, live workshops helps me to learn the supine PCNL. I am thinking that supine PCNL has significant comfort and cost effectiveness, and it is less risky than the prone position. So I started the supine PCNL. These are the advantages of the supine PCNL, like it saves time, it is cost effective to the patient, it is comfortable and less risk, it has less risk factors. Supine PCNL nearly saves time by 20 to 30 minutes of the operation theatre. Only single draping is required and whole procedure can be done in supine or modified lithotomy position. There is no need to change the patient from the lithotomy to supine and from the supine to prone, like as we do in the prone PCNL. As less operation theatre time is required, less drapes are required, duration of anesthesia is less, so drugs used are less. So at the end, there is significant cost saving of the patient. It is comfortable to the surgeon. Surgeon does the procedure while sitting in the chair. There is less duration of the surgery, so less fatigue. Surgeon need not to wait till the patient is prone. Small fragment of the stone easily come out by positive pressure and gravity drainage of the returning irrigation fluid. And it can be combined with the flexible ureteroscopy whenever it is needed. There are less number of assistants are required, only just as single OT assistant is sufficient, like ureteroscopy. No need to change the position during whole procedure. It is less exhaustive to the all OT staffs, including OT assistants, assisting staff, due to less duration. As we know, to make the patient prone under anesthesia, at least we require 2 to 3 OT assistants. And of course, anesthetists are very happy as making patient from the supine to prone. And in the end of the procedure, from the prone to supine is not without a trace, risk, and effort. Patient comfort. When we do PCNL in the supine position under spinal anesthesia, patient is also comfortable in the supine position compared to the prone position, as supine is more natural position and comfortable to the patient. Total cost saving also gives economic comfort to the patient at the time of the discharge in the private hospitals. Theoretically, there is less chance of the colonic injury as colon is more posterior in the prone position compared to the supine position. There is less radiation to the surgeon as hands are out of the radiation field, and there is less chance of the sepsis as system is always under low pressure due to gravity drainage. I think there are some limitation of the supine PCNL. Bilateral supine PCNL cannot be done as simply as the prone PCNL. Some surgeon has habit to operate while standing. They feel that sitting position is uncomfortable. Returning irrigation fluid always comes on the surgeon's body, so there is chance that this fluid may soil his OT dress. When multiple tracks are required in the complete Staghorn calculus, it may be difficult due to less available working space in the initial period, at least for the new surgeons. Movement of surgeon is from the down to up and in the horizontal direction in the supine position. It is reversed to the prone PCNL. How I am doing? This is my preferred position. It is called modified lithotomy supine position. I always do PCNL in the general anesthesia, otherwise it is contraindicated. Patient in the supine position, I first mark 11th and 12th rib, iliac crest and posterior axillary line. Patient side line should be exactly on the operation table, or rather it should be 1 inch beyond the edge of the operation table, so that we get more space. Ipsilateral side should be elevated to 30 to 40 degree centigrade from the operation table. I use 1 liter normal saline bottle wrapped in the cotton towel, one behind the lower chest and another behind the buttock. I keep lumbar area free from the support so that I will get more working space. Ipsilateral lower limb should be medially rotated and somewhat straight. Opposite lower limb is in the modified lithotomy position and ipsilateral upper limb is rested on the patient position as shown. My puncture is under fluoroscopy guidance. After doing the cystoscopy and RGP, ureteric catheter is kept and preferred puncture site is 2 centimeter below and nearly 2 centimeter behind the tip of the 12th rib. It is same like the prone PCNA. Direction of my needle is toward the renal angle. It makes angle of 45 degree to the plane, horizontal plane of the patient's body, and it should make angle of the 45 degree to the spine. This is Siam position. Siam in the 0 degree position helps to assess the depth of the needle tip. Siam in the 30 degree tilted toward the head end of the patient helps to assess the relationship of the needle tip to the desired calyx to be punctured. In the 30 degree Siam position, if the needle tip is superior to the desired calyx on the Siam, then in the reality, needle is posterior to the desired calyx to be punctured. So we have to adjust needle accordingly. And I always try to remain posteriorly to be on the safer side to avoid the injury to the viscera or colon. This is the relationship between the Siam position and the needle tip. In the 0 degree, you can see the tip of the needle is in the desired calyx. But in the 30 degree, you can see tip of the needle is superior to the desired calyx. Means in reality, you are posterior to the desired calyx. So accordingly, you have to adjust the needle to enter into the desired calyx. This is my puncture. It is usually 2 centimeter below the tip of the 12th rib and 1 to 2 centimeter behind the tip of the 12th rib. This is second case of the puncture. It is 2 centimeter below the tip of the 12th rib. This is iliac crest. This is 11th rib and this is 12th rib. This is schematic diagram of the supine puncture. Here, saline bag is put to elevate the edge and you have to go through this plane. This is cranial end, this is caudal end. This is puncture with needle with guide wire in the C2. This is second case puncture with guide wire in the C2. Now I want to show small video clip of the supine puncture. This is short video clip This should be efflux, and just like in the prone PCNL, we should go through the papilla of the calyx. I want to close this.
Shashikant, I think your videos are not playing. Just
It
move.
is played, na? Not playing.
No, it's not playing. So you can just move to the next slide.
Okay. But it is playing on my screen.
And our screens, it is just making rectangles.
You have to
Your video is not.
screen share and share the screen again from where you are playing the video.
Okay.
Just open it.
Okay.
Just disable screen sharing first and then start screen sharing again from the where you are playing the video.
What we will do otherwise, Shashikant, is we'll go to Aditya's video. You present the next slide and then we'll get you back to present your videos.
Okay, no, just give me 1 second.
Sure, sure.
There is some, it is coming.
नाही खाऊन टाकतो तुला नाही मिळालं
Shashikant, are you there? Shashikant? Dr. Aditya?
Please unmute yourself.
Okay, yes.
I-
Hello.
Yeah, you move to the next slide. We'll come back to you at the end with your videos. Someone will help you how to get the videos playing. Just
Okay.
you and because
There is nothing, okay.
Yeah.
Again, this is, this is the last slide, last but one slide. As I have explained, my experience is very small, limited to 4 cases. I have started supine PCNL. Are you able to hear me?
yes, we are able to hear you.
I have started supine PCNL 2.5 months ago, and I have done 4 cases. In the first case, I was unable to puncture the kidney. After 2 to 3 attempts or 4 attempts, I have decided, I have prone the patient and completed the procedure. In the next 3 cases, I have done complete stone clearance without any complications. I feel very happy to start supine PCNL. Once started, you will be able to do it. It is like prone PCNL. We should get accustomed to the position. And I think we should try in all cases. It is effective, it is easy, cost effective and comfortable. This is just like going by the train in the second class and standing, and is the prone PCNL. When you go by the first class and travel by the metro, you are faster and comfortable. Thank you.
Thank you, Shashikant, for starting this meeting and presenting your experience. What's very heartening to see that we have Dr. Joseph Philip Raj, who has joined, Dr. Lal Manali, Dr. Thatte, Dr. Harshvardhan, and one person who's popularized PCNL across, also Dr. Sanjay Khadagi, a close friend of Dr. Kulkarni. So we have all the people in the panelists who do supine and prone. So I'm sure it's going to be a fantastic meeting. Aditya, may I request you to please present your video and take us through your technique as well as step-by-step approach to supine PCNL.
Yeah, thank you, Dr. Joshi, and I'm really thankful for Pune Urology Society for giving me this opportunity to share my work. Dr. Shashikant has nicely summarized what are the advantages of doing supine. Well, I will not repeat them, but I would just start my presentation with one statement that anyways we have not exchanged any wedding vows with prone PCNL. So let's parallelly date supine and maybe it works for you or you may have both. So whenever I propose supine, the first question is why should I do it? Shashikant already explained. And next thing is, if I do it, will I get puncture? Yes, getting puncture, if we follow the correct technique, if we follow the principles, it should not be a problem. The other question comes, will I be able to do all the cases, all type of patients? Yes, almost all type of patient, wherever PCNL is indicated, one can do it, in my opinion. And will I be able to tackle all the stone? Absolutely, absolutely, you can tackle all the stone. And I will focus my presentation primarily on the technical aspects, and that's why I've limited my presentation in the form of videos. And I'll be just sharing my video. Okay, perfect. So, okay. So I would like to first start by explaining the position. I would say why position is important, because that is the first struggle, that how I should position my patient. Prone position is very much straightforward. You put the tubes and you turn the patient, so not much confusion. That's the pure simple advantage. Simplicity has its advantage. But supine has another way advantage, that your position can be modified to the need of the surgery, type of the stone, and type of patient as well. So one has to first decide what is their goal in particular patient, in terms of patient anatomy, and what are the limitations, if anything, with the patient, and what stone size they are dealing with, or they are planning to do simultaneous lower tract access, other side access, or ECIRS, which we say endoscopy combined method. So I will proceed with what position I use. I have used many positions, but we now limited to frankly oblique supine modified lithotomy position. Before giving this position, we have to first mark the anatomical landmarks. So the posterior axillary line is to be marked, and it has to be marked in anatomical position, whether in one can use in sitting position, standing position, or lying supine, where the torso is not twisted. After giving the position, we should not try to mark the line. Why the line is important? It gives an anatomical safety in terms of in terms of avoiding injury to any intraperitoneal organ. In general, 99% times the line would cut through the tip of 12th rib. So many times I palpate for the tip of 12th rib and I use it as a landmark. But 12th rib is a very floating landmark, and sometimes it can be short. So one should not really rely singly upon the tip of the 12th rib. And having said that, if you are behind the posterior axillary line and the patient doesn't have a clear-cut retrorenal colon, you can't have puncture as well as colonic injury together. Either you will have colonic injury or you will have puncture if you follow the correct technique. So how do we position the patient? First, we mark the landmarks. Then first step is we lift the ipsilateral buttock on the lithotomy poles. We put the patient in lithotomy, and just around 30-degree lift is given under the same side buttock. This lifts the buttock and makes the flank free. Then we rotate the torso to the opposite side. This hand goes to the other side, and this is how the torso is rotated. And in the third step, we lower the lithotomy pole down further to make it a modified lithotomy. Here you can see that this leg is straight and this leg is out open, so that it gives space from below in terms of giving access to the surgeon and doing endoscopy or any lower tract procedure. And we do have why we straighten this leg, I will explain further in the video. And if I can go back to the last slide, you can see there is so much space there. Entire back is exposed in front of you. So in terms of the first limitation which comes in mind, whether will I have lesser space compared to my prone PCNL? Absolutely not. You know, you can see entire same side of the back is exposed in front of you. So lack of space is never ever a problem. So after we have given the position, so this position also allows simultaneous other side access or the endoscopic combined intraileal surgery for the same side. And after giving this position, we can pain drape the patient in single step. So what we generally use to save the cost, this is a ready-made Surgiwear PCNL drape which we use, or you can use a disposable one as per your preference. And we simply cover the patient with single one drape. So entire patient, everything is covered in one drape, and other leg, which part of the leg is slightly exposed, we use the second part of the C-arm cover, which we orthopedic people use. We don't use much. The second part we generally use to cover the leg. So even if you use disposable drapes, you can comfortably cover the cost with single drape. So after that, I'll explain the infracostal or infracalicial puncture. So what is done is, so this is the pelvic calculus straightforward case. I think this is the ideal case, and some secondary stones are also there. This is the ideal case for somebody who is starting supine PCNL. So now the lower tract surgeon, he is pushing the contrast. We do the RGP like we do in normal PCNL, and the operating surgeon stands by the side and he marks his puncture. Puncture is to be marked perpendicular to the skin surface, and it has to be behind the posterior axillary line. Once we have marked the puncture, we go in and we initiate our puncture. The first line where we ensure that we are getting the puncture correct. You can see it here. I'll just slightly put the video below. When we are starting the puncture, you can see the kidney is moving. This is the indentation over the kidney. This is the first indication that your puncture is not grossly above or below kidney. If your kidney is not moving, you've gone past the shadow of retrograde pyelogram, and your kidney has not moved a bit, that means you are grossly out of plane. So you need to adjust it accordingly. So this will also avoid any kind of colonic injuries. So if you are going too anterior and then you try to adjust while you are too much inside into the patient, and then you try to adjust, then it is possible that you were already in the colon and then you readjust and go back and hit the kidney. So if your kidney is moving, that means your first plane is correct. It may be slightly above or below. So now here we can see we have made the puncture. Apparently it looks like we are inside. Now we have to correct it and check it in another plane. The C-arm is to be rotated craniocaudally, not like conventionally what we use for bullseye, that C-arm comes towards you. Rather, the upper end of the C-arm goes toward the cranial, toward the head of the patient, and the X-ray tube which is below that goes towards the legs of the patient. So now once we rotate the C-arm, we have to see what is the movement of the kidney. Slightly we have to understand this is the X-ray tube, these are the legs. So in terms of the X-ray tube, if the needle is going anterior, same means if the needle is going towards the caudal end, if the needle is going towards the leg, so it is anterior, it is going as the same side of the legs, then it is the needle is anterior to the kidney. If the needle is going opposite to the legs or going towards the cranial end, then it is posterior to the kidney. One can make own short forms mnemonics to remember in the quick time where they are exactly, because sometimes it can get confusing whether they are anterior or posterior. So if the needle is anterior, the needle will move towards the leg, anterior same side towards the leg or the X-ray tube. If the needle is posterior, it will move opposite to the X-ray tube, so posterior opposite. So ASPO, this is this mnemonic we are using to memorize whether we are anterior or posterior. So now we can see in this, now we are rotating the C-arm. You can see the needle is moving caudally towards the legs. So that means we are anterior. Now our puncture needs to be corrected, and we have to adjust our puncture to posterior side. So now we have again made the C-arm in 0 degree. Now you can see my hand. Now I'm going more posterior. Here you can appreciate the indentation of the calyx as well. I hope it is visible. You can see even the calyx is getting indented. So these are subtle things. Now more than 90% of times I don't have to rotate the C-arm, because these subtle feedbacks you have to see while making the puncture whether you're in or not. Now I'm very sure I'm in, and I've still confirmed it by rotating the C-arm. Of course, you can withdraw the stellate and see that water comes out and you are inside. So now other thing is there, is it only for infracostal or lower calyceal or mid calyceal puncture? No, we can do a supercalyceal puncture, because advantage in forcemal position, because torso is 70-80 degrees to the table, the upper part of the back is also exposed, and we can make a normal puncture where we will normally make a puncture in prone PCNL. So I would like to slightly summarize the anatomy. The kidney is placed upside down anteriorly 30 degree, and laterally accesses laterally upside down 30 degrees. So now we can see the upper calyces are more posterior and medial, lower calyces are more lateral and anterior. So so our puncture planning also has to move in accordance with that. Here we can see how I plan my puncture. If it is an inferior calyceal puncture, it will be a infracostal puncture. Mid calyceal will be either infracostal or above the 12th rib, and superior calyceal puncture will be between 11th and 12th rib, or sometimes above 11th rib. So, and this is quite medial position for the puncture, and it is almost the same place where I make my puncture in prone PCNL for the superior calyx as well. So the superior calyceal puncture technique is not very different, and it can be equally effective in terms of making puncture and accessing the kidney. So this is the primarily superior calyceal stone, and you can see I've marked my puncture sites and I'm making the puncture. I'm going in again. I think I'm in, and yes, I'm not sure. I'm rotating the C-arm. You can see the needle is going towards the leg. So it is going anterior, same, I'm anterior. I have to adjust my puncture and I have to go more posterior. So once I adjust the puncture, I can simply go in, and then I can pass the guide wire. So we have passed the guide wire. Now dilatation again is a, what method we use a single step dilator. So the first step, we use the Alken needle and cannula, and once we pass the Alken cannula, one may decide to have a safety guide wire if they want, and they can take out the main guide wire. That has its own advantages while stone comes out. And the other thing is, one surgeon can comfortably remain seated away from the C-arm. We don't have to move C-arm back and forth while we are accessing kidney, because it doesn't come in the way, and our hands are never exposed to the radiation while making puncture afterwards. Most of the stain fragments, they keep coming out on their own. I rarely use a forceps. Sometimes stone gets stuck, and there you can see if the stone moves from to the inferior calyx while inferior calyceal puncture, one can go from superior to inferior calyx to clear the stones. And on the unlike other cases, one can go from inferior to superior calyx also almost 60-70% time in my cases, and especially if you're using a mini nephroscope that allows added maneuverability in terms of stone clearance. Stone bulk is not a problem. Once you are in the system, you can take out whatever amount of the stones, whether you want to do with tube, without tube, tubeless procedure. Everything it can be comfortably done, and patient can be closed. I'll just quickly share another video, which is the another advantage is the endoscopic combined intrarenal surgery, or the simultaneous bilateral surgery. What method we use for that? I'll just quickly share that video. So what we do here, first say normal, the position remains the same. We give normal Fosmer position, the one I explained. Now the lowest surgeon starts with doing putting cystoscopy, ureteric catheter, doing RGP, and the surgeon on this side starts with the puncture, and while surgeon is getting puncture, doing passing guide wire, doing dilatation and everything, the other side, the lower tract surgeon starts doing, he can put a excess sheath on the same side if they want to clear upper ureteric stone, or if the stone bulk is too much, then one can do a simultaneous stone clearance in the same system, that is endoscopic combined intracranial surgery, or surgeon can access the other side also. One can do RIRS on the other side simultaneously. We have done at least we do one case per month, many times of 1 to 2 cases every 1 or 2 months, where we do operate simultaneously, where the main stone bulk is big on this side and other side has smaller stones. We can clear both of them in single sitting at the same time. And you can see the excess sheath is passed on the other side. Here the PCNL is happening, other side RIRS is happening, and so both things can be done simultaneously and comfortably. And of course the advantages remain the same. The other thing is, because of COVID times, I would say many anesthetists are apprehensive about giving general anesthesia. So we do our supine PCNL, ECIRS, simultaneous bilateral endoscopic surgery, mostly under spinal anesthesia, and it is very convenient to the patient, anesthetist, and in fact the overall OT turnaround time is less, because general anesthesia, reversal, and again getting in, getting out, so that takes more time, what we have seen. So in terms of that also is an advantage. And last thing to worry is about colonic injury. We have not had in many hundreds of cases, we have not had a single case of colonic injury. The only time one can get a colonic injury when they try to correct their path when the initial entry was wrong. They are too anterior and they try to correct midway and try to go posterior. If you are too anterior, you are not hitting the kidney. Come out anterior completely and go again. That's the way. And unless this is an obvious case of retrorenal colon, it is unlikely one would hit the colon for this. And I guess I've completed my 20 minutes, and I'll be happy to wind up my talk. Thank you so much, Dr. Joshi and Pune Urological Society.
Dr. Aditya, fantastic talk, and you did perfect justice to the video. 3 questions to you. Do you do CT scan before doing every PCNL?
Yeah, in my practice, like almost like 5-7 years, I do NCCT, all cases. All cases I just do NCCT.
Colon in that, or just for the stone?
Actually, it is now part of habit. My entire planning is based off NCCT. So it includes colon, it includes stone, hardness, Hounsfield, everything works out ultimately.
So last 5 years, how many supine PCNL, how many prone PCNL?
Counted, no, prone I have not done. All I have done, prone I have not done. Since 2016, I have not done a single prone PCNL.
You never had a chance where supine has not worked and then you had to give the prone in the same anesthesia?
So far not, but I don't think if I now turn, I will be able to make a puncture in prone.
And one truthful answer, which I'm sure you will always give, what is the worst complication you have had?
Worst complication, obviously bleeding. It is the end of the day, it's a PCNL. You can have bleeding, and it bleeds like any PCNL. If it is, sometime infundibular tear, something. And there was one patient we had, he has a huge stone bulk, 13-14 centimeters total staghorn, complete staghorn, 14 centimeter stone size. We had to make 4 punctures, and he suddenly developed the anesthetist said that the patient is having difficulty in breathing, and he developed hydrothorax. So that was a thing, because supine-CALYCEAL amplas somehow got pulled out while surgeon was busy doing from the other tracks. It got pulled out and all the water seeped into the pleura. If the amplas was secure. So that's the thing. I mean, that is the worst thing I remember.
not related to supine actually.
It's any PCNL luck.
Thank you, Dr. Aditya. I'm sure we'll have more questions. May I request Dr. Karthikeyan to start his presentation on what are the challenges in doing a supine PCNL in various scenarios. Dr. Karthikeyan.
Can you see my screen, sir?
Yes, fantastic.
Good evening, everybody. I'm Karthikeyan from Trichy. It's a proud moment for me to present our work in front of the stalwarts of urology. I thank Dr. Pankaj Joshi and Dr. Nitin sir for giving me this opportunity. I take this time to introduce Trichy Uro Education Foundation, which was formed under the guidance of Dr. K.S. Devanathan. Our team comprises of Dr. Govindaraj, Dr. Maheshwaran, Dr. Vikram, Dr. Vinod Khanna, Dr. Suresh and myself. Our idea of forming this foundation is to facilitate the training of urology education and learning in the non-institutional setup. And we are happy to conduct the first hands-on workshop on RIRS, Supine PCNL and ECIRS in the last year, which was attended by nearly 200 delegates. And I thank Dr. Aditya for an excellent talk on the basics of supine PCNL. Our Indian supine master had done justice to his talk. These are the common challenges we usually face while doing supine PCNL. The challenge may be related to patient positioning, or the patient age, or habitus of the patient. Intrarenal and extrarenal anatomy may possess a challenge while doing PCNL. I will share our experience of doing supine PCNL and how we circumvented these challenges. We are doing supine PCNL since 2014, and we have not done a single prone PCNL since 2016. And our last PCNL for prone was done for a bilateral renal calculus when we thought of doing it simultaneously. There are nearly 8 to 10 ways of positioning a patient in supine for PCNL. Dr. Aditya has described his FOSML position. This is our position of placing the patient in supine. This is Bart's modified supine lithotomy position. We keep the patient in lithotomy, then we keep a bolster, one in the upper chest and the other bolster in the pelvis. We don't keep the patient more tilted to the other side. We keep a tilt of around 15-degree tilt to the opposite side. If needed, we may have to support the opposite side with another bolster. We make sure the patient is brought to the edge of the table. We keep the flank free so that we can have a good space for our scope to move. Compared to the FOSML position, here the patient is tilted only to 15 to 20 degrees, whereas there around a 60 to 70 degree tilt will be given, and the ipsilateral leg will be straightened. When we have an obese patient, the challenge here is to deal with the anterior abdominal fat and the fat overlaying the thigh. We usually strap the anterior abdominal fat and pull it towards the opposite side so that it won't come into our field of surgery. As Dr. Aditya has nicely pointed out, the marking is a very important part of supine PCNL, and it has to be done in the patient sitting or standing, and if it done in the supine position, it should be done before tilting the torso to the opposite side. In this picture, you are seeing two lines, both of which are starting from the posterior axillary fold. The upper one was marked after tilting the patient to the opposite side, whereas the lower one was marked with the patient lying supine. If we do the puncture taking the first line, and if we go behind that, the chance of injuring the colon is high, or we may not able to get the puncture right. We had two cases of colonic injury in our series, both of which had happened because of this mistake in marking, which was done by the staff or someone after turning the patient to the opposite side. This image is a CT of a 140 kg lady whose stone to skin distance is around 22 to 25 centimeter. The stone bulk was predominantly in the pelvis and the lower calyx. After positioning the patient in our BART's modified supine lithotomy position, the marking is done. The puncture was taken. We don't usually guide we won't go by a fixed point like pointing the needle towards the opposite shoulder or pointing downwards. We go according to the anatomy. We usually go parallel to the horizontal plane, and as Aditya told, we will take the 30-degree or 20-degree tilt cranial, and depending upon that, we will position our needle either a little anteriorly or posteriorly. Most of the time, we may have a little mobile kidney, which may be a hindrance in the initial series, but as we go in confidence, we can easily deal with this. Here, as the stone to skin distance is quite significant, we have a little amount of needle to puncture the lateral part of the calyx. Almost the needle is completely in. Here we are using the Store's 3-part needle. If you see here, the needle is almost parallel to the iliac crest. We have to grow almost parallel to the iliac crest, and the iliac crest is coming in our field of activity. The kidney is low lying also, and as the standard dictum says, we will go by jerky movement and we'll make sure the kidney is moving every time we go in. And as we go close to the kidney and as we enter the calyx, we make sure the kidney is, the needle is moving within the pelvic-calyxal system. Simultaneously, we confirm with the antegrade flushing of saline. And once we got the efflux, we'll put the guide wire in, and most of the time we'll be able to park the guide wire safely into the ureter. Another common challenge in supine PCNL is the mobility of the kidney. Look at the first picture. The right kidney has almost moved to the opposite, beyond the vertebra. It is looking like a left kidney. This can be very well managed by having a counter pressure anteriorly, or even if that doesn't work, we can put a ureteroscope from below and stabilize the kidney, and we can take the puncture. These are some of the tips to handle a hypermobile kidney. And this is one interesting case which we did recently. We always do a plain CT KEB for all our PCNLs. According to the CT, it is a pelvic stone, and we thought of clearing it with the RIRS. We have put the scope inside, and to our surprise, we couldn't see any stone. And we did a retrograde contrast study, and we couldn't see the lower moiety and middle calyx lighting up. So we brought the scope down almost up to the VUJ, and we couldn't see any second lower moiety or the duplex ureter lighting up. And we did a stone guided puncture with the aid of ultrasound. We dilated and we did a supine PCNL. We cleared the stone, and we passed the flexible ureteroscope from above to the supine ampullate sheath, and we could safely go up to the L4, L5 level where the confluence was seen. The lower moiety ureter was identified by a concomitant simultaneously done ureteroscopy from below. So this is the greatest advantage of supine PCNL. Whatever we could do in prone, we can do in supine. But there are some things which can be done only with the supine, like a combined intrarenal surgery, or a simultaneous lower calyxal access, or a simultaneous access to the opposite kidney. These are the greatest advantage of doing a supine PCNL. And most of our queries while starting a supine PCNL is whether can we access the upper calyx through a supine PCNL. And it is very easy to reach the upper calyx through the lower calyx. And this has been proved by a nice study by Guido Gusti, and it got published in Journal of Urology, where they have clearly concluded that it is approachability of the endoscopy through the lower calyx to the upper calyx is significantly higher in supine position than when compared to the prone. This is a upper calyxal diverticular stone. It's a nice, interesting anatomy where we have a large calyx sitting on the top of the upper calyx. We initially tried with the RIRS, and we are not able to reach the upper calyxal infundibulum, the calyxal diverticular infundibulum, and we had a little contract extravasation also. So we thought of converting into a supine PCNL. With a little modification in the position, we are able to start the supine puncture. And this kidney was relatively more mobile, and we could get the puncture after several times. The kidney was more mobile, and the upper calyx as well as the whole kidney is moving. And as said before, movement of the kidney and movement of the calyx, indentation of calyx are the definite signs that our direction of puncture is quite good. Now the kidney is moving more medially, and our puncture is not to the point. All these things are done in the monoplanar, and then finally we were able to keep the kidney at one position, and we are able to get the puncture. In soon we will be able to see the indentation of the calyx, and the puncture will be right. This is a real-time video. Now the calyx is getting indented and our puncture is right. We have overshooted and we have come back, and now we are in. Yes, we are in now. Doing any endourology procedure in a pediatric population is a challenge, and supine PCNL is no different. Actually, pediatric supine PCNL is quite safe and quite comfortable, like the way we do in adult population. This is a 1-year-old child with a 2 centimeter pelvic calculus, and we have positioned the child in prone like the usual way we do. There is not much space left behind the posterior axillary line, and the puncture and the dilatation are all same. One important point we should take care of in pediatric population is the kidney would be very mobile, and it is safe to keep a counter pressure anteriorly so that we have a controlled dilatation. Once the dilatation is done, the maneuverability of the scope is relatively easier in supine PCNL in pediatric population compared to the prone, and the stone can be easily dealt in the same way. At the end of stone fragmentation, we confirmed the complete stone clearance, and the stent is placed. We usually do tubeless. We rarely keep PCN tube following PCNL. Most of our PCNLs are supine and mini perc. We usually keep only the DG stent. And we have an interesting case recently where a 2-year child presented with bilateral pelvic calculus. We plan to do a supine PCNL. We could evaluate the child. I will keep this taskbar above so that we can have a better vision. Yeah, and our planning was to go through a lower calyx, and we are able to get the puncture with above said maneuvers. And once we go in, we started fragmenting with holmium laser. To our surprise, we could see a lot of smoke coming out while dusting, and we got a lot of fumes coming out from the ampulas tube, and everybody was sensing a characteristic rotten egg odor, and we thought of having a cystine stone in this patient. And if you see a lot of fumes coming out from the ampulas, the stone was completely cleared by holmium laser. You could recognize the fumes coming out to the mini perc sheath in this case, and clinically we thought it's a cystine sheath, and which was confirmed by crystallography analysis that the stone is going to be stone was a pure cystine stone. This rotten egg smell of cystine stone is very characteristic, and we don't even need a stone analysis to confirm that. And doing a supine PCNL in a horseshoe kidney is another challenge. The challenge here is the kidney is mal-rotated and the pelvis is facing anteriorly, and there was a lot of bowel anteriorly overlaying the pelvis and the calyx. If you see here, the stone was like occupying the entire shallow pelvis at the confluence of upper and lower pole infundibulum. We thought of doing a supine puncture with ultrasound guidance. Here we could get a safe window posterior to the bowel, and the puncture was quite straightforward. We could easily get the indentation of the calyx, and the puncture was quite safe, and we could dilate the system and complete the supine PCNL. So even in anomalous kidney, supine PCNL is quite safe. If you see the literature, the chance of bowel injury is only 1% with supine PCNL, whereas it is nearly 10% with prone PCNL. In case if you have a retrorenal colon, we can safely use a ultrasound to avoid a colon. Even a enlarged spleen or a enlarged liver, if it comes in front, we can use the ultrasound to guide your puncture and to get a safe puncture. The greatest advantage of supine PCNL is getting an aid from below whenever needed. Here you can see a parallel calyx in the lower pole, two calyxes parallel to each other, and the stone is there in the more medialmost calyx. If we come to the lateralmost calyx, we could not get this stone cleared, so we use the ureteroscopy to guide this puncture, and this endovision guided puncture is one of the greatest advantage of supine PCNL, though they are not routinely required, but if needed, we can do that. We can see the endoscopic as well as the CM image in that where the endoscopy is assisting the supine puncture. ECIRS is another greatest advantage. Usually in ECIRS, we do the lower calyceal stone cleared with a supine puncture, and we use the flexible scope to clear the middle and the upper calyceal stone. On the left, you are seeing the image of a flexible scope. On the right, you are seeing a nephroscope image. After clearing the lower calyx and pelvic stone, the flexible scope was introduced. The flexible scope, with the help of a basket, with basket the upper calyceal stone, passed on to the supine sheath, through which the stone is grasped with the grasper, and the stone is cleared. This is called the passing the buck from one scope to other, and this is very with this ECIRS we'll be doing quite often in our center, and we are happy with the results. Sometimes we may have to do a supine PCNL through the upper calyx, and we have to use the flexible scope to clear the middle and lower calyx, like here. The patient had a large stone in the pelvis as well as stone in each of the calyxes. The supine puncture was done to the upper calyx, and the calyx was almost filling the stone. The stone was almost filling the calyx, and we have to park our scope in the renal parenchymal level, and we have to fragment the stone to gain more space. After clearing the upper calyxal stone, we could see the calyx in the middle calyx is almost parallel, and we will not be in a position to enter from that position. So we put the flexible scope from below. The flexible scopy and the irrigation from below helped the stone to get cleared through the upper calyxal infundibulum. The stones are passively cleared in this case without the need for any grasper. By means of whirlpool effect and the aid of retrograde scopy, we could completely clear this stone. I will quickly finish my talk in a couple of minutes. We not only by learning a supine PCNL, it will be help in urolithiasis, but also in cases like fungal balls or in papillary necrosis, when the patient presents with urosepsis with little change in supine lithotomy position with the help of ultrasound by the bedside itself, we will be able to put a PCN like this. This patient had a fungal ball where we were able to keep the PCN tube in the supine position and give wash and clear the fungal balls. Another benefit of doing a supine puncture is to drain the perinephric collection. This case had a perinephric collection following a RIRS, and there was indentation of the calyx with the collection, and there was a stone lying outside the pelvicalyxal system. With the help of ultrasound, we were able to direct our puncture towards the collection, and turbid urine was drained, and we could keep a pigtail safely in this position, and the patient was bailed out from sepsis. And these are the other benefits of doing a supine puncture, learning a supine PCNL. And to conclude, we have a regular fellowship with us for a duration of 6 months. The fellow will be given enough exposure in supine PCNL, RIRS and ECIRS, and we'll be happy to answer any queries. Thanks to team Pune, USA for giving me this opportunity. It's a pleasure and privilege to present in front of the stalwarts of USA. Thank you.
Karthikeyan, that was an amazing talk. You almost took through all the challenging scenarios. And I think what is very essential is whenever there's a sepsis and we have to put a PCN, the PCN tends to come from behind. So if patients don't mind an abdominal drain, if you have a PCN coming anteriorly, that's best. Another question for you is when we all do training, when my boss used to say give a kidney position, it is always a flank position, lateral, let it be for laparoscopy, pylolithotomy, stone or pyeloplasty. PCNL and the stone surgery is the only place where I've heard someone saying supine or prone. So my question to both of you is that will someone do what is called as a lateral PCNL? Give a lateral position, you can do supine, you can do prone in case there is an advantage. So have you ever tried that?
No, sir. The greatest disadvantage of having a position like that is the orientation to the intrarenal anatomy. Sometimes we get confused where are we, whether we are anterior to the kidney or posterior to the kidney. It is better to have one fixed position and to direct our puncture based on that rather than having a in-between position. Maybe Aditya might have a different view.
No, this is just a thought. Maybe someone will come up with a lateral PCNL where you can access both.
It's almost lateral. It's just reaching there.
That's what I was seeing in your position. It's almost lateral. Excellent, Karthikeyan. You have done fantastic justice to this. May I invite Dr. Jaideep Date sir to present his view on when he would do a supine and when he would prefer doing a prone PCN.
Pankaj, I think another thought came to my mind. Why not sitting PCNL?
Maybe.
You can do anterior, posterior, bilateral simultaneously. One anterior, one posterior.
Outpatient OPD.
And under awake anesthesia.
And simultaneously from below. So everything is possible. So new position for PCNL. Somebody can try it out.
Yes, sir, I agree.
Okay. So I'll be brief because I think most of the things have been covered by everybody. Shashikant, Aditya, Karthik have done a wonderful job of telling us about supine advantages, when they will do it. Both of them have been doing it in almost all cases. They haven't been doing any prone PCNLs. But when somebody is trained in a particular way, it is difficult to change to a different way. And I have been doing PCNLs for the last 30 years. And obviously we started with prone PCNLs. But there are issues with prone PCNLs, and we know that very obese patients' positioning can be a problem. Anesthetists will always be cribbing about giving anesthesia in a prone position to an obese patient. Somebody with having neck issues, somebody had a neck fusion or some problem with the neck, anesthetist will be difficult to give them prone position and keep the neck stabilized. Somebody with renal insufficiency, obviously prone position is an issue. So I did my first supine PCNL in 2002, and that was in an obese patient. And anesthetists were not very keen on giving him prone. So I did my first supine PCNL way back in 2002. And then again in another patient with a bamboo spine, again prone position was going to be an issue. So I started hesitantly by starting it on very select group of patients where anesthetists were not keen on giving prone position. And we used to do about 2 to 3 cases per year initially. And being a very different orientation, I used ultrasound in all punctures in the beginning. So where do I do PCNLs in supine position? 90% of my PCNLs are in prone position because that's the way I have been trained and I'm very comfortable. Whenever there is an upper ureteric stone and a kidney stone, or maybe an upper ureteric stone where I feel that while doing a ureteroscopy, a large fragment is likely to fly up, I will give the patient a position wherein I can access ureteroscopically as well as in supine position if need be. If I have to do a supine PCNL, I'm still hesitant in doing large bulk upper calyceal stones. In those cases, I would still prefer prone PCNLs, but lower calyx pelvis, middle calyx pelvis, very nicely done. I still avoid very big staghorns where a lot of intrarenal manipulation is expected. I do not want to do supine unless the patient factor like respiratory problems or other factors indicate. For example, this patient, large upper aortic stone with renal stones, perfect for ureteroscopy and supine PCNL simultaneously. This is the case we did today. 120 kg patient, chronic liver disease, chronic kidney disease, came in urosepsis. He had pyonephrosis and these stones. His platelets were 50,000. His patient, the WBC counts were 30,000. This patient came about a month ago when during COVID times, and we had to put in a PCN in supine position in him, drain the kidney, and today we took him up for supine PCNL. So we give him this modified position. We have a small tube which is draining the lower calyx. Now we have all these stones, big pelvic stone, and puncture through the lower calyx. You see the problem. This is the longest amplage sheath that is available, and it is almost going inside the kidney. Even with the long Storrs nephroscope, we could not reach the distal part of the pelvis. So the thing that you would do supine PCNL for has some problems. This obese patient, you would normally prefer to do it supine because putting him prone is a problem. But as you know, the lower calyceal supine PCNL access is probably the longest access available to the kidney. If you see all the papers, the length of the access from the kidney to the skin is longest in supine, and the length of your instruments can be an issue. So this is the problem I face today. So I'm really wondering how I'm going to do the other part of the stone which is left behind where my instruments are not reaching, and the stone is really hard, and it's still about 1.5 centimeters of hard stone remaining. So I was not really keen on doing a retrograde surgery to deal with that stone after about 1.5 hours or 2 hours of surgery in this high risk patient. Another problem with supine PCNL which I hate is I am always wet. All the irrigation is coming on my drape, on my gown, and no gown is waterproof, and I am always wet. As I told you, the longer access to the infrarenal, there is a difficult intrarenal manipulation if the angles are not good between the lower calyx and the pelvis and the upper calyx. And proper posterior calyx identification may not always be possible. We inject air during some of our PCNLs to identify the posterior calyx. Here, this maneuver is not possible. You can always argue whether this perfect posterior calyx puncture is always necessary or not. That's a different discussion. But this again is an issue why you cannot identify the posterior calyx by injecting air. In the last 30 years, Dinanath and Pune hospital where I worked, no anesthetist has ever refused me a general anesthesia and a prone position. They crib, but they will always give. So not being able to give prone position has never been an issue for me. So my question is, why change something which has worked for you for 30 years? So why change? But I know that it is essential to know supine PCNL. It is essential to know the technique. You should know when to use it, and you should use it judiciously. Now we have papers which say that you can do stag-on, you can do almost any procedure in supine position. I think it can be done. If you are trained in it, if you are oriented to the anatomy and a certain position, I'm sure it can be done. But it's up to you when to use it. Thank you.
Date sir, thanks a lot for your talk. And as I said in the beginning of the meeting, I saw my first supine PCNL way back 10 years ago. I think it's a great opportunity. You had a chance to do it today, and we also have seen the amplats going. So very nice and very thoughtful insight. May I invite Bapat sir, please, sir. We are so happy to see you regularly in the USP meetings, and I just invite you to please suggest your views on the supine and prone PCNL. Sir, can you please unmute yourself? I'll try to unmute you. Bapat sir, we are not able to hear you. You just need to unmute yourself.
Can you hear me now?
Yes, sir. Yes, sir.
Okay. Basic principle in science. Development and progress is a continuous process. If something is being developed, one should not look at it as a bad thing. Because I've gone through that. When I started doing endoscopy, people scoffed at me. Whereas in the PCNL, people scoffed at me. Now, those who are used to do supine PCNL, which we have been doing it, now slowly changing on to prone PCNL, absolutely I have no objection. Just a question of how much you can do, how much you are trained, and the safety of the patient is the prime interest and ultimate result. So all is accepted in the science, provided it follows all the basic principles of the science, especially in this kidney stone, the stone removal presents prevention of complications like bleeding and all that, which you can't promise in the beginning. It has there, and still, if somebody is doing it and getting good results, let them do it. Those who are trained to do in the PCNL, in the prone position, let them do it. It's an open field, all are equally good. That's what I feel. Thank you.
Thank you, sir. So given a chance, it is just about training in which way you can do a prone or a supine PCNL.
Whatever best for you.
Whatever best for you. That's
With
good.
best results of the patient is good.
Yes, sir. Nitin Gargil said you had raised your hand. You wanted to ask. Kulkarni sir, your thoughts, please. Sir, please unmute yourself, sir.
Very nice talks. Dr. Sanjay Kharage from Nepal is here. And I started using the Pepsi straw after seeing him do PCNL with a Pepsi straw. Is the thinnest possible amplac sheath. And we also use the same Pepsi straw for suprapubic cystostomy, acute suprapubic cystostomy, through which we can pass an endoscope for obliterative strictures, and we can pass a Foley catheter. So any Sanjay Kharage is there, or any comment about this using Pepsi straw as an amplac sheath?
I spoke to Dr. Khadagi. He's just recovering from.
Okay.
So he said I'll be on the chat box, but as we said, we'll have him at the next meeting. So we will also see his technique of the middle calyx and puncture.
Okay. Okay.
I'd like to put in one thing there. One urologist of Nepal was the first person to use a straw that is used for drinking coffee as an amplac sheet.
So he's
amplac sheet for passing, especially smaller scopes, like ureteroscopes and all that. And for each case, he used a different amplac, that is different straw, clean, fine, and he's getting good results. It's just an innovation. You have to try it. provided fluids you require.
That's true. That's true. And, I've seen so many straws with Kulkarni sir's unit and what he was saying, PCNL as well as the suprapubic. So amazing, amazing. I hope Dr. Khadagi is listening to all these things and we would really like you to join us next month for the USP meeting.
Dr.
Dr.
Ketan
Gargi?
Vartak wants to
Yeah.
ask something or make a comment. Ketan, please.
Dr. Vartak, Dr. Gargil, you can unmute. Everyone can
Hi.
unmute.
Can you hear me?
Yes, sir.
Yeah, just a small comment. Normally we use the initial puncture needles so many times, and then once the sharpness of the needle goes, in a ptotic kidney it becomes difficult to puncture, and that is more so in supine PCNL, because the supine PCNL the kidneys keep on moving. So if you use a new needle, the puncture will be very difficult, very easy. So in ptotic kidneys, I usually discard the old needles and use a brand new needle so that the puncture is absolutely easy. The kidney doesn't move so much, because normally the needle only will keep on pushing the kidney up. So for supine PCNL, probably a newer needle will be beneficial.
Ketan sir, virginity has its advantage, whether PCNL or something.
Yes.
Young man. Dr. Gadgil?
Yes, good evening to all. And first thing, let me congratulate and let me give Dr. Shashikant, Dr. Aditya, and Dr. Karthikeyan, and Dr. Jaideep, obviously. The Shashikant has started recently 4 cases. Aditya and Karthikeyan have been doing 5 years, no prone. Let me ask 2 questions to each, I think. Aditya, in your second case of upper calyceal puncture, you showed, I believe the puncture tract was perpendicular to the calyx. Normally we say it has to be in the line of the calyx. So do you think is that a problem either in prone or supine?
Sir, absolute in line with the calyx and the infundibulum will start somewhere around 8th rib maybe. So what we use is kind of triangulation, and this patient was in spinal, so we could not use the normal technique of breath hold and all. But if the full inspiration, it almost comes in line. If we go above between 11th and 12th rib, or above 11th rib, 10th or 11th.
Yeah, I agree. But when you go perpendicular to the calyx rather than in a straight line, don't you think there will be a torque or some bleeding or injury to the infundibular?
Sir, this looks perpendicular because of the angle of C-arm. In this supine, we look at a different angle. Had same puncture, same side, same way would have been done in prone, it would have looked more straight.
Okay. Dr. Karthikeyan?
Yes, sir.
What Dr. Jaideep Date pointed out, in obese patients, when you took up that 140 or 120 kg case, did you have in mind the distance between, you said something 25 centimeter stone to skin?
Yes, sir.
So did you keep in mind to have a longer nephroscope, a longer sheath?
Yes, sir,
or you went with
definitely.
the normal scope and normal sheath?
No, sir. Whenever we take up a obese patient, we have to take this SSD into consideration, because we will be needing a longer needle, longer access sheath, and a longer nephroscope. Without that, it may be difficult, but there are ways to bail us out if we don't have one, like having a stitch with the amplas sheath so that we can pull it out. But if we have regularly doing these kind of obese patients, it is better to have a longer needle, longer amplas sheath, and longer nephroscope.
Yeah, a very basic question to everybody: what is the normal length of nephroscope sheath, and what is the length of extra long sheath and nephroscope?
22 centimeters.
Nitin,
yes, sir.
May I ask you one question?
Yes, sir.
This long distance of the calyx from the skin in a very old patient, Deepak Kirpika had a solution. He used 2 umbrella sheets. One was a larger one, larger diameter, and used a smaller diameter. So it was telescoped partially, and he could manage to increase the length and completely erase PCNL. This is just a point, the innovation. In long, very obese patients, this can be done.
And one question to Jaideep, Karthikeyan and Aditya, I think that has been asked in the chat box also. Don't you think in a supine, because of the gravity, the PC system is most of the time is collapsed? And if there is a bleeding, then the vision can be a problem?
So actually, this the bleeding or anything if it happens in supine, it is easy to handle better than prone because we'll have a lower access to the lower tract and we'll be continuously irrigating if needed. Initially, the collapse of the calyxes may be a difficulty, but usually over a period of 5 to 10 cases, we'll be able to overcome this difficulty. Whenever you feel the calyx is not adequately distending, we can start irrigating from below with the help of a ureteric catheter and we can have a good vision as well as we can have a dilatation of the calyxes. Aditya, your views please.
Yeah, very important point that irrigation from below can be done, and ECIRS, if we are putting a RIRS scope, that also can irrigate very fast with the pathfinder. Other thing is I generally keep both the water channel open, so both the normal saline bottles are open, and you can use more height, of course. And yes, you can. I put a safety guide wire outside the emplas, and I don't keep a guide wire in the emplas, and I put a rubber nipple which we use around the cystoscope, around the nephroscope. That snugly fits. If I need it, I slide it and block the system. So that fills it like anything, and there's never need of. There's no less space inside.
And to Jaideep, last question. Jaideep, what are your indications for supine now?
I just told you in that presentation that I do it when I upper ureteric stone, then renal stones. When I'm doing it, I know that part of the or even with a large upper ureteric stone, when I feel that part of it might go back into the kidney in a dilated system, wherein I'll have to use an RIRS to deal with the system. But a dilated system and a RIRS can be a problem. The fragments don't kind of clear off very nicely. So I prefer to do it supine PCNL and get all these fragments out. So if you have a simultaneous ureteric stone and a renal stone, this supine combined approach is quite good. And somebody with respiratory difficulties, cardiac difficulties, somebody with neck problems, all those patients, I would do supine.
Okay, and indications for prone for these two, Dr. Aditya and Dr. Karthikeyan, if at all. Your indications for prone.
When we are planning to do a bilateral simultaneous PCNL, we think of prone. Otherwise, nothing special, sir.
Okay.
I want to. Hello.
Yeah, Dr. Shashikant, please.
Yes,
I
Shashikant.
want to clarify, Nitin sir. If there is emplas size and your nephroscope size is properly, or your nephroscope is snugly fitting into the emplas sheet, there is good vision in the supine PCNL also. If your emplas is larger and nephroscope is smaller, then there may be problem with the vision.
Generally, 2 French difference is good. 24
2
sheath
or 4
and
French.
22 nephroscope, 21 nephroscope, it fills very nicely.
Yes, 2 or 4 French.
Yes.
And anybody can answer, Dr. Aditya or Karthikeyan, who is the inventor of ECIRS? Indian or abroad?
Professor Scofone, sir. Professor ECIRS-SUPINE from Italy.
Okay.
He coined the term ECIRS, and he had published a book on that way back in I think 2007 or 8. They started doing ECIRS there, and this book got published in about ECIRS almost a decade back.
Okay, great. And Aditya, coming back to, I think you have seen something on the StarPulse group. There was some report from China. Bilateral, simultaneous, ureteral access sheath, right side, left side, single surgeon. What do you think? I think it's too much of an imagination and too much of a to go through a male or female urethra, 2 access sheaths, 2 RIRS, either done by 2 surgeons or 1 surgeon.
Yeah, 2 urethra, 2 sheath are okay, but 1 urethra, 2 sheath is too much. Ek man mein do talwar is difficult.
The patients would then come to Pune afterwards. So
yes.
So,
There's scope for everyone.
May I give you an example?
yes, sir.
As I was a patient of huge, almost total kidney stone, there were two teams operating in the same kidney by PCNL, one from the upper pole, one from the lower pole, two different surgeons, two different nephroscopes at the same time in the same kidney. This was a president from Coimbatore. Has anyone experienced that? At last I got shown two teams of surgeons, two nephroscopes, two generators, one going from the left, inferior calyx, one going from the upper calyx, and they are all eating in the stone.
I'm sure, Bapat sir, you asked this question to the gentleman who was performed it. What was his
I have
answer?
not done it, but the question is, it was presented. And we had one of the surgeons from South Coimbatore.
Dr. Kandaswamy had presented, I remember that.
Uh,
Dr. Kandaswamy had presented that.
I don't want to mention a name, but nobody agreed on that.
And Nitin sir, about the access point, I would just like to say, because how this question of simultaneous bilateral RARS came, see, my point is, as long as while doing the procedure, it doesn't become a challenge and it looks like a jugglery, and it is safe for the procedure, I guess everything new is more than welcome. But apparently some things may look too aggressive, like somebody seeing simultaneous bilateral endoscopic surgery likes too aggressive, one surgeon below, one surgeon. What's so hurry? You can finish on
Yes, and okay, have you tried bilateral simultaneous PCNL? One surgeon, right kidney, left kidney, both doing simultaneously.
Yeah, I
Have you
guess
thought
one has to devise I think some people have presented and shared in groups also. I guess one has to divide a very 1, 2, 3, 4, 5 steps, and they don't come in way of each other. They don't struggle. They don't fight for C-arm. They, then the patient suddenly get compromised. I'm okay with bilateral RARS. I think bilateral PCNL, any surgeon would think, if suppose something happens, I mean, PCNL is any day little unpredictable, where we are going, it's a blind procedure to begin with. Bleeding can happen, anything is still.
No, that's what my point is. I think it's too heroic for any surgeon to think, and just to present or I have done it or I can do, I don't think it's correct. I think Dr. Bapat sir perfectly says whose kidney is it? It is the patient's kidney. So
Nijin, there is one question I want to ask Dr. Aditya.
Sir,
when you do two simultaneously,
so I don't do.
Two scopes, how many of them get stricture afterwards? Nobody talks about it?
No, sir, I don't do bilateral RARS. That was some other gentleman who was doing. Dr. asked the question.
So, what's the hurry?
What's the hurry? True.
That is the best part. I think PCN is one surgery which brings in adrenaline from all the urologists, and the adrenaline is highest in the first half an hour of the surgery when puncture and everything is. So I really thank Bapat sir. Thanks a lot, Dr. Aditya, Dr. Karthikeyan, Dr. Date sir, and Shashikant. I think it's going to stimulate some minds, and maybe in the next decade we'll have half urologists doing prone supine, and it might just change the way as we move forward. So thanks a lot. Yeah, and we have many friends, senior colleagues, senior members joined across the country, even internationally. They all are your fan following. So thanks everyone to join for the Urology Society of Pune monthly meeting. Thank you. This is being recorded and we will upload it on the YouTube soon, maybe by tonight in the next 1 hour. Thank you.
Thank you, sir. Thank you
very much.
Thank you all.
Bye.
Dr. Reddy, thanks a lot to you for the thing, for the support. Thank you.
Thank you, sir.
Thank you all.
Thank you.